Hello, everybody. My name is Professor Dr. Mohamed-Naguib Wifi. I'm a professor of medicine and hepatogastroenterology in Cairo University. And my lecture today is about the status of H. pylori in Egypt. Is it a hype or an iceberg? So we say that H. pylori, despite any reality, any truth, anything said about it, it is always everlasting and never-ending hype. Why we call it a hype? Because there is plenty of talks about H. pylori on the social media, even between peers and friends, even in the apothecary. You can find medications and the treatments for H. pylori, and they recommend it for you. And you can get treatments outside the medical care by the OTC or over the counter and over the shelf remedies that they say that they can cure you from such a dilemma. So let's get back very anciently, and we say, hooray! H. pylori is an African pathogen. H. pylori is migrated from Africa 60,000 years ago. And researchers showed that the genetic diversity of H. pylori is similar to its host, decreases with geographical distance away from the East Africa, which harbors the H. pylori now in abundance. So modern humans were already infected before their migration out of Africa, and the pathogen remained within human hosts since that very ancient time. What about the current or the more recent history? We all know, of course, Professor Valery Zavoreski in the late 19th century, who first described H. pylori and the shape of H. pylori. Is a Polish physician. And of course, the story went up to the very famous duet, Warren and Marshall, who gained the Nobel Prize for their description of H. pylori in 2005. Of course, we are all aware about the modes of transmission of H. pylori. It's not a new news. It's person to person, fecal oral, oral, gastro-oral. And we all know that the risk is higher in younger age, underdeveloped countries, and lower socio-economical status, which is, of course, present in Africa in very common sense. So, what about the magnitude of the problem here in Egypt, the prevalence, the age distribution, the gender? I collected all the data about such thing, and we found that the prevalence of H. pylori among Egyptian adults ranges, according to the studied populations and the years of publication, between 13% and 90.9%. Very wide range of incidence, of course, and the prevalence in pediatric population ranged from between 13% to up to 72.38%. Average is 44.4%. And the adult population, of course, is between 26.2 and 90.9. Average is 67. So the average in pediatric population is almost 44.5, or in the adult population about 67. The pooled population of the general whole population is about 62.5%. So when we say the prevalence of H. pylori in Egypt, we say it is 62.5%. Of course, it's a very major prevalence of this infection. And here are the graphs that demonstrate the figures I mentioned. So from where did come such figures? Comes from the publications about that, the Egyptian publications. So I found 21 Egyptian publications about adults ending from year 1993 to 2016. And as we can see that the least percentage is 26.2% in the healthy controls of coronary heart disease, and the highest is among the healthy controls of medical personnel, which is almost 91%. I found only 7 publications in the pediatric population. As we can see that in very young pediatric population, newborns 7 to 9 months is only 13%. And when they come to the age of being school children, the incidence and the prevalence of H. pylori infection increases very much to become almost 72 point something percent, almost 72.5 percent, of course. So what about the testing of H. pylori, considerations, precautions? Of course, we have to keep in mind the precautions that everybody knows, that to detect H. pylori, except for the serological test, we need a bacterial viability. This bacterial viability necessitates that antibiotics would have been stopped for weeks at least before testing, and the acid suppressant should be stopped by 1 or 2 weeks according to the type of this acid suppressants before doing the testing. So, due to this marked variability in the reported prevalence and the heterogeneity of the studied population, of course, there is a grave need for a well-designed epidemiologic study that accurately estimates the average prevalence of H. pylori among Egyptians. So, what if I do this? This study, of course, should consider symptomatic, asymptomatic population, different geographical regions, gender, age groups, and based on such results of this actual and well-designed prevalence studies, I would be furtherly able to determine the disease burden, required diagnostics, complication rates, treatment costs, screening, method to prevention, and all would be initiated upon a solid base, of course. So, what about the Egyptian presentations, lesions, and the H. pylori in endoscopy? Of course, there was a study about that, and about 154 dyspeptic adults consisting of 56 males and 78 females, about 60% females and almost 40% or more males. The main presenting symptoms were abdominal pain, heartburn, nausea, vomiting, hematemesis, and melena. But also some of the patients presented bloating and surprisingly diarrhea, easy fatigability, and loss of weight. About their endoscopy showed that almost half of them, they have gastric erosions, 53%. About 30% have mucosal granularity, and we'll see the mucosal granularity, especially in younger adults. And about 15% had actual gastric ulceration in the endoscopy when they got examined. When we talk biopsy, we found H. pylori in almost 90% of such patients, and detected H. pylori by the biopsy were almost 40% cocci and 40% cocobacilli, and to a less extent, only 20% were in the bacilli form, which is very, very strange. What about the therapy and antibiotic resistance, which is of grave importance, of course, when you speak about the H. pylori? This was a very good report published by the year 2018 by abundance of Egyptian professors. Of course, Dr. Borai is a very dear colleague of mine. He was the main author in this publication, and the results showed that there is the studies were heterogeneous regarding the drug doses and duration. Standard triple therapy was still achieving acceptable eradication rates in both adults and pediatric population, but only if they were used for 14 days. Using the triple therapy for periods less than 14 days, of course, showed low rates of eradication. We have to notice, of course, that this publication was pre-COVID era, before the tremendous usage of antibiotics at that time Of course, I know that this study, if was repeated again now, maybe the results would change. The results in this research showed that the first line would be the triple therapy, provided there is no previous exposure to macrolides. Salvage therapies were concomitant therapy and levofloxacin-based triple therapies, and of course the load method, which is proton pump, levofloxacin, doxycycline, and of course nitazoxanide. So what about the antibiotic resistance in H. pylori, which is a very important subject? Most of treatments of H. pylori in the market nowadays, they have cure rates of less than 80%. And of course, we know that this is not accepted, except of course the bismuth based and some quadruple therapies, they have rates higher than 80%. So this equals ineffective treatment regimens. So we need, of course, to address things like antibiotic resistance, uncooperative patients or uncompliant patients, high gastric acidity, and pleomorphism, gene pleomorphism, like interleukin 1B or the cytochrome B2C19. So, of course, everybody is aware where come the resistance, about the compliance and gastric acidity and genetic and so blah, blah, blah. But of course, on the top of everything is the grave and abusive usage of OTC antibiotics. It is the main star here about the causation of antibiotic resistance, either to H. pylori or even to any other pathogen. When we have the published data about the Helicobacter antibiotic resistant stratified by region, we found that in Africa, metronidazole is almost 76%, clarithromycin is almost 30%, levofloxacin is 17.4%, amoxicillin also is very high, reaching up to 73%, and tetracycline is almost 50%. So what about Egypt? About Egypt, the published data about the antibiotic resistance, and here I quote from this very, very good research published in the year 2022. So it is more or less a recent publication by Professor Mohamed-Naguib Wifi and his colleagues, and he showed that metronidazole resistance is 100%. Penicillin, 95%. Rifampicin is 90%. While on the other side, moxifloxacin is only 10%, levofloxacin is only 20%, and the doxycycline is only 15%, and midway resistance in erythromycin, which is 65, and clarithromycin, azithromycin, both of them, they have 40% of antibiotic resistance. What about the combined antibiotic resistant rates in Egypt? Of course, comes on the top of this is the amoxicillin, metronidazole. But we see that amoxicillin, clarithromycin, and metronidazole, clarithromycin is a little bit less, 40%, but amoxicillin, metronidazole is 95%. Of course, when we use 4 antibiotics, resistance comes very, very low. And when we use 3 antibiotics, the resistance is rather also less or lower, like we see in clarithromycin, metronidazole, amoxicillin, and in the metronidazole, amoxicillin, levofloxacin. Of course, presence of levofloxacin in the therapeutic regimen renders the resistant rates very low. Okay, so conclusion in the Egyptian patient that H. pylori had more than 90% resistance for metronidazole and amoxicillin, modest resistance for erythromycin, azithromycin, and clarithromycin, and very low resistant rates for moxifloxacin and levofloxacin. So we need from that to translate from trial and error to antimicrobial stewardship. We don't need to see the patient who comes to you complaining that he's been treated for H. pylori once, twice, and even 3 times before approaching you to find a solution. We need an antimicrobial stewardship, and I think all the world now is talking about the antimicrobial stewardship. So excluding antibiotics where pre-existing resistance is expected is the first step. Of course, if we have history and or susceptibility testing, of course, this is better to achieve this, and a complete history of previous antibiotics. And we all forget to take this complete and very vivid history of previous antibiotics from our patients. And of course, to sometimes patients, they hide medical problems and medical treatments that they think it's not important. You as a physician must explicitly show to your patient that every data is crucial and important. Of course, this declining efficacy of standard treatments warrants a novel treatment strategies. So we have seen in the last master 6 that there is now a tendency towards using bismuth quadruple therapies showing very low resistance as first lines. Of course, the usage of B caps or potassium acid competitive blockers like vonoprazan also shows promising results for the eradication of H. pylori in the more recent publications. Of course, some trials, of course, to add on some adjuvant therapies to the usual triple and quadruple therapies. For example, we have this Egyptian research about using the Lactobacillus reuteri, and it found that the eradication rates were better in the cohort who received Lactobacillus reuteri as an add-on therapy to the usual and the standard triple therapy. My take-home messages that the average prevalence of H. pylori among Egyptians is 67 in adults and 44 in 0.4 in pediatric population. Main symptoms among Egyptians is abdominal pain, heartburn, nausea, vomiting, hematemesis, and melena. Of course, H. pylori detected in endoscopy in almost 90% of patients. And of course, the resistance rates, as we know, for metronidazole and amoxicillin are the highest, and the lowest for the moxifloxacin and levofloxacin. All this warrants, of course, a well-designed study to determine the actual prevalence, disease burden, required diagnostic, complication rates, effective therapies, treatment costs, and of course, the screening and the prevention, and all that would be initiated on solid. This lecture is recorded on my YouTube channel, Mohamed-Naguib Wifi. Of course, feel free to visit me and find my other lectures. And thank you very, very, very